For today's session, we will continue with the part 2 of obesity chapter, overweight and obesity. So on page number 367 onwards, causes of obesity, 367 onwards, those who have the textbook. So some markers that are found even in the early life, even as a fetus, certain markers are found which could indicate some lifelong onset of chronic diseases. Okay, so the first cause is fetal programming and early onset of childhood adulthood diseases. This is a relatively very new concept. We do not have exclusively facts or exclusive evidence that pinpoint certain factors that would definitely come out as adulthood diseases. We don't know that yet, but it has gained certain attention. Okay, David Baker and his colleagues have observed on cohorts. Cohorts means a child who was having, or a fetus who was having certain markers during the pregnancy, and they followed the growth of these fetuses well into their childhood, their adolescence, and their adult life. Okay, so it's a very long study. Okay, so this is a cohort study. It was done to understand the relationship between birth weight as well as the weight at the age of 1. Okay, and also adult morbidity, mortality due to any coronary heart diseases, cardiovascular diseases, hypertension, type 2 diabetes. Okay, is there any relation between what was the birth weight of a child? Okay, at birth, what was the weight of the child, and what was the relationship between developing certain uh, lifestyle diseases or non-communicable diseases later on in life. Okay, so this is a fetal programming cause. Okay, the main question here is what is the intrauterine environment for an intrauterine growth retardation baby that leaves an everlasting impact. So any child who was a preterm baby, okay, any child who was born as small for gestational age, preterm, or any child who had undergone intrauterine growth retardation, not able to be fully viable given the gestational period. Okay, do these children have a normal, healthy childhood, adolescence, and adult life, or do they have some other co-inhibiting or onset of chronic diseases way too early than their peers? Okay, so this is the question that is this programming is trying to answer. Then we have amplifiers and modifiers. There are several factors during the subsequent life of an individual that could lead to obesity. Okay, obesity basically it's lack of exercise and also increased calorie. Okay, that is what leads to obesity. Um, Smoking, stress, strains, high fat diet, deficiencies of micronutrients, antioxidants. Okay, these could also be, uh, they can also act as amplifiers or modifiers of obesity. Okay, just like the junk food and cola culture of the West, even in India, you have your own culture that is leading to obesity, which has crept into the Eastern world as well. Early onset of ischemic heart disease, hypertension. Okay, that is also happening in young women as well. Earlier, only menopausal women or women who have attained menopause used to have cardiovascular diseases, but now it is happening in young women as well. Weight at the age of 1 is one of the identified important determinant by various healthcare workers who find that whatever is the child's weight at the age of 1 is very significant to determine what kind of diseases this child will have as an adult. Socioeconomic factors, feeding practices, how the child is taken care at home, environmental and emotional factors under which the child is growing. Okay, all these are the factors, modifiers, usually not amplifiers but modifiers that definitely affect the child's postnatal environment. Postnatal environment means growth environment where the child is growing up. Normal birth weight babies, they usually have a better intrauterine environment. Okay, they belong to better nourished mothers. Okay, and definitely when the mothers are well nourished, there is a lower level of stress at the mother's home or wherever the child is brought up. Okay, so low stress in life the child will observe since a very young age. and that would definitely lead to low adulthood morbidity and mortality. Then we have the thrifty gene hypothesis. This suggests that earlier periods of human development, some individuals store up energy as fat, and during this period of when the individual or child is storing up energy as fat, during this time when malnutrition is happening, those stored up energy will successfully help the person not to become the victims of malnutrition. Okay, so this is the thrifty gene survival advantage, and this is kind of an advantage which Indians also have. Okay, but what happens is that if this gene is present in affluent societies, okay, big rich family, where there is a surplus of food, there is no uh, there is no decrease in food. Okay, storing up of energy as fat will lead to more problems. Okay, and this thrifty gene adaptive mechanism is usually seen in Indian households because this gene kind of we Indians have. We have the gene, we have the DNA evolution in which in minimum food we can survive. Okay, with minimum calories we can survive because India in its past has seen a lot of famines. Okay, so we kind of have this similar thrifty gene and we can survive with very less food. But now India has surplus of food. Okay, majority of the households in India has access to good nutrition, better nutrition, and over nutrition as well in form of junk food. Okay, so that is creating this disbalance. That is the reason why uh, there is this loophole of Indians who do not come under the obesity ratio, who are not obese, but they still suffer from diabetes or other cardiovascular diseases. Then you have genetic factors. So, obesity is the expression of complex interaction between genetic and environmental factors, including food intake. So, one third of the variance of obesity is given in the population. Parental obesity Parental obesity, especially when both the parents are obese, it is a strongest determinant of the child also being obese. Okay, even and in this case, the resting energy expenditure, that is your basal metabolic rate, okay, that is also inherited. That is also, we say it is you inherit your basal metabolic rate. Whatever your family's basal metabolic rate is, you also adapt in the same area. Then you have syndromic obesity. Okay, this is also very common in children. Any child, usually, if they have dysmorphic genetic syndrome, okay, usually with facial features, physical features, short stature, hypogonadism, intellectual disability, okay, when kids have this, usually they suffer from obesity, Prader-Willi syndrome, Beckwith-Wiedemann syndrome, Lawrence-Moon Bardet syndrome. These are the different types of syndromes associated with when children suffer from these kind of syndromes. Usually, they are afflicted by obesity as well. Okay, sex-linked recessive obesity is also associated with mental retardation, microcephaly, large ear, and an obese child. Okay, so these are syndromes, genetic syndromes inherited. Okay, which in which obesity is also a symptom of these syndromes. And on top of these environmental factors, lifestyle, eating patterns, and eating energy dense, obesogenic foods, high fat, high sugar, junk food, soft food. Okay, these has also caused the explosion of these symptoms to be more common in children. Then you have constitutional obesity. So, this is seen in children due to excessive calorie intake. It is more common in infancy, around 6 years of age, or even in puberty. So, these children are taller, they have uh, advanced bone age. Puberty sets in very easy, very early. Okay. And this is the most kind of a common type of obesity. Even the genitalia of the children, it appears disproportionately small, and it is embedded inside fat, because when the prepubescent children get obese, when prepubescent children get obese, they usually undergo this type of symptomatic obesity. The neuropsychiatric obesity, any malformation or any deficient function in the hypothalamus pituitary gland, or even if the child has some brain lesions, okay, psychological disorders like bulimia nervosa, okay, these can also lead to obesity. It can dysregulate your appetite, involve signaling that culminate in ventromentral region of the hypothalamus, and because of which hormones that are secreted to control your appetite does not function well. You do not know when to stop eating food. You do not feel satiated. You do not know when to stop eating food. You keep on eating food, and that's how it leads to obesity. Then you have endocrine obesity. Cushing syndrome is the most important condition. Turner syndrome, that is also another syndrome in which there is a short stature, short height, and obesity because due to lack of sex hormone. Hypothyroidism and growth hormone deficiency syndrome, that could also lead to obesity. Polycystic ovarian syndrome in women is also associated with late onset obesity. So any endocrine disorders that could lead to obesity, these are few. Evaluation on markers of obesity. How do you understand markers of obesity? Checking the BMI, tracking BMI, and with the BMI, prevention and early intervention has to be done. Weight for age, weight for height, skin fold thickness, waist hip ratio. Okay, these things has to be checked. Apple shaped and pear shaped obesity, what kind of obesity you're suffering from, is also checked. Your DEXA scan can be done to understand what is the fat percent, muscle percent, bone density. Okay. So these evaluation can be done, and with which different markers of obesity can be found out. Coming to management, diet, physical activity, cognitive behavior therapy, surgery, medications, there are different principles of management of obesity. So diet, there are few diets, like examples we'll discuss here. Atkins diet. Atkins diet is a high protein, low carbohydrate diet. It mainly consists of meat, cheese, and avoiding starches as much as possible, fruits, sugars, processed diet. It's very similar to keto diet. Okay, high protein, low carbohydrate diet. And then we have formula diet. It's a balanced eating plan. In formula, you will eat meal for which 40% of the calories derived from carbohydrates, 30 from protein, 30 from fat. Okay, so this on based on this formula, you will eat your food. Pre-prepared meals are also available. Then hay diet, also known as food combined for health. It also involves keeping starch food separate from protein food to help in digestion. So you will not eat starch based and protein based food in the same meal. Then you have Weight Watchers Pure Points. Weight Watchers group, it's a weekly club. Okay, every week once they will have their session. Uh, in this session, they meet, the Weight Watchers meet, they check their weight, and they will have group discussion, and club leader will share new news, hints, and tips to how to reduce weight. more easily. So people who are suffering from obesity or who are overweight, they come together, they participate in this Weight Watchers group. Then we have low fat diet, LFDs, it's called LFD. So many diets emphasize the reduction in fat intake as much as possible. Fat is also high in calories. So very low calorie diet around 800 kilocalories can also induce rapid weight loss, but this rapid weight loss can be gained very quickly. Okay, and they are generally not recommended for a long term. The low calorie diet, again, it's an energy restricted diet. Your energy will be between 800 to 1500 kilocalories, not more than that. But it should contain a balanced protein, fat, and carbohydrates, minerals, and vitamins as well. Just give me 1 minute. So, low calorie diet, 800 to 1500 kilocalories is the range. Within this, you should have a balanced protein, fat, and carbohydrate. Usually, you do this to reduce your diet, so you reduce your fat in the body. Okay, and long term, it is not prescribed. High dietary fiber diet. So, if dietary fiber supplements are more effective than placebo when it is given in diet of 1200 to 1600 kilocalories, but however, weight loss achieved was not that different from all the other diets. So, it is kind of a placebo effect that dietary fiber has. Very low calorie diet, typical diet that consists of just 600 to 800 kilocalories or less per day. It should not be continued for more than 1 month. Minimum protein intake should be kept in mind while even while on very low calorie diet. Decreased alcohol intake. Alcohol also has nearly as much as energy as fat, around 7 kilocalories. Okay, so if excessive amount of alcohol can also lead to obesity. Some model diets we will discuss here. Model diet 1. In diet 1, avoid ghee, butter, oil, okay, gravy, milk, cream, sugar, jaggery, chocolates, bakery items. Okay, this is diet 1. It's a low calorie, dense items like idli instead of high calorie, dense items like upma. Okay, choose idlis over upma. Okay, it can induce a deficit of approximately one third of calorie intake, and it is practicable also, and everyone can accept in the family as well. And avoid eating in between meals. This is model diet 1. For even for a 10-year-old child who is obese, you can follow the same diet. Then diet 2. This is a highly restrictive diet which is rich in protein fast diet, PMF. Okay, so it is with or without extra carbohydrate, but it takes the body into a state of ketosis. You require very close monitoring of children who are on PMF. A little addition of carbohydrate can also increase the insulin. fat utilization as well. Renal cardiovascular functions should be monitored when a child is on PMF. And PMF usually provides 1.5 to 2.5 gram of protein per kg per day based on ideal weight of the child. And the protein source is from lean meat, fish, eggs, etc. Supplement of calcium, potassium, and multivitamins can be taken. And if you're adding some salad or low calorie vegetables without oil, it can be added. There are two forms of PMF with added carbohydrate. And for adults, like it is under strict supervision. No oil is used in salads. Tea and coffee is always black. Meat is never fried. Okay. So oil is completely removed from the diet. No eating between the meals. Little salt. Don't drink too much of liquid. Avoid any sugar. It should be followed very rigidly and cannot be used on children. In a protein PMF diet, protein modified fast diet, when you use it with carbohydrates, 100 gram of carbohydrates are given. Then coming to physical activity, for adults, it is mentioned from the health education authority, it is mentioned that adults should try to build up gradually to take half an hour of moderate intensity physical activity for 5 or more days a week. And in this moderate intensity exercise, which includes brisk walking, cycling, swimming, dancing, gardening, okay, these are good options. Specific requirement of physical activity for people who are obese, that's another topic. So under that we'll go through just few points. Build up should be done slowly, 30 minutes of moderate intensity exercise a day. 30 minutes, you can do it 10 minutes, 15 minutes here and there, okay, which adds up to 13 minutes throughout the day. That is also completely fine based on whatever is the comfort zone and routine and schedule of the individual. 45 minutes or longer is considered as an optimal weight loss strategy. Gardening, shopping, household work, walking, etc. Okay, if you increase the amount of these activities in your day, you will see the change in your body. Decrease the time spent on sedentary activities, like try not to sit down for more than 30 minutes at a time. Consider weight bearing exercises like walking and climbing stairs. Okay, and because of which your muscle mass will be like you will be able to conserve the muscle mass in your body, maintain strength in your body, resting metabolic rate can be maintained in the body. Find physical activities that you find enjoyable, that you look forward to do. Coming to behavioral modification, so it should be reinforced: eating behavior, physical activity. Okay, these choices, you have to make these choices on a daily basis. So certain behavioral modification is required. Okay, so it comes under different stages. How behavioral modification usually will not take place overnight. Okay, so first stage is pre-contemplation. So in this stage, the individual has no intention to change the behavior at all. They are completely fine with who they are, what their body weight is. Okay, they're completely fine with that. Okay, so they don't intend to change anything. That is the pre-contemplation phase. Then you have the contemplation phase. In the contemplation phase, people are aware that there is a problem and they are seriously thinking about it and they want to overcome it. Okay, but they have not made any commitment yet. Okay, that is the contemplation phase. Then we have the preparation phase. In the preparation phase, the stage that combines intention and behavioral criteria. Individuals at this stage are intending to take action in the next month, and within, like, as soon as possible they will take an action. Okay, they have like taken many unsuccessful actions since few time, but now they want to really do well, they want to really take a strict action. That is the preparation phase. Then active change is when the individual modify their behavior, experiences, and environment in order to overcome their problems. Okay, so they have started exercising, they have controlled their calories, they have removed junk food, etc., from their diet. Then you have the maintenance stage. This stage, people work to prevent relapse. Okay, they consolidate this gain attended, like what they have reduced the weight, they have gained, achieved their target weight, but now they have to maintain it. Okay, so they go into a maintenance phase in which they will do everything, every activity they will do so that they don't relapse back into the previous self. These are the behavioral modification in different stages. Types of behavioral therapy: you have cognitive behavior therapy, under which people should have a self monitoring, keep a track of whatever you have eaten. Okay, stimulus control. Okay, reduce exposure to stimuli, avoid like when you're going to shop for something, don't shop for snacks or anything, avoid, completely avoid snacks shopping, don't keep snacks or unhealthy snacks in your home. Coping with cravings at high risk situation: how do you cope with it when you're craving for something very sweet? Okay, make healthy choices. Stress management: how to relax yourself. Self learned self control techniques. Okay, breaking the cycle of breaking your self control. Problem solving skills. Okay, so these you have to adapt, these all comes under cognitive behavior therapy. Then modification of disordered eating: how do you change your disordered eating if there is a child who has a binge eating problem? Okay, weight management, mood management, managing work and family, relapse prevention, avoiding self-defeating thinking, encouraging the child not to feel defeated, improving body image, learning to disassociate body image with self-esteem. Okay, so these all techniques will be taught in modification of disordered eating patterns. Usually any disordered eating condition, all these areas have to be worked on. So a psychiatrist or a counselor can help you with this. Then drug therapy, will not do drug therapy in detail. Okay, so I'll just go through some drugs that are used commonly. Orlisat is used everywhere, it is a licensed drug. Okay, and it is recommended for potential patients to lose at least 2.5 kg in a month. Okay, it's a prescription based dosage. But here the documented evidence is required that a person should have a BMI of 30 or above, only then it can be given. Otherwise, people with BMI of 20 and 28 and above, but they have other disease conditions like diabetes, hypertension, etc., and then also this can be given, or Orlisat can be given. And Orlisat is approved for children also in USA. Next, you have chitosan. Chitosan, works like a fiber. Okay, it will go and bind with the fat and cholesterol, and it will not allow the fat and cholesterol to be absorbed in your intestine. That is how chitosan works. Okay, before you eat your meal, half an hour before you eat your meal, you have to take this tablet. Bulking agents are also used, like isabgol. Okay, these are also used to make you a feel of fullness, give you a feeling of fullness. Then metformin in case of insulin resistance in PCOS cases, any teenagers or adolescent girls are suffering from insulin resistance, metformin can be suggested. Then you have sibutramine. So sibutramine, it creates a feeling of satiety by acting as a serotonin and noradrenaline reuptake inhibitor. So it will give you a result of that you are satisfied. Okay. Even after eating a very small quantity of food, you will feel like you have ate a lot of food. Okay, so it gives you satiety. Then you have phentermine. It is an appetite suppressant. When you eat phentermine, you will not feel hungry. Okay. Fluoxetine. So it is a limited kind of it's a selective serotonin reuptake inhibitor, and it is neither licensed or recommended for uh, weight loss purpose. It acts very similar to cybertamine, gives you a um, fake feeling of fullness or feeling of satiety or satisfaction after that you have after eating a full meal. Then surgical treatment, you have restrictive procedures and surgery for super obese patients. Restrictive procedures like gastroplasty, in which you change the shape of the stomach. So in you change the shape of the stomach in which that your stomach will get filled up with food very quickly. So you will eat very less. Okay. But the stomach will empty very slowly. Okay. This is gastroplasty. Then laparoscopic gastric binding is done. Laparoscopy surgery, you don't keyhole surgery. An adjustable band is wrapped around the stomach so that it will not be distended. Okay, if the stomach will not be distended, it will not have enough space to occupy more food. So you will automatically eat less. Okay, then gastric bypass surgery is done. Part of the surgery is cut. Because part of the stomach is cut and is joined with your duodenum. Okay. It is usually the gastric bypass is the first line procedure used in obesity surgery. Then you have jejunal ileal bypass surgery. Again, jejunum is cut and it is directly connected to the ileum. Then surgery for the super obese patients. Liposuction is done in which fatty material under the skin will be removed. That is liposuction. Then jaw wiring procedures not recommended any longer because in jaw wiring procedures person will not be able to chew. They will not be able to open their mouth and put food inside and chew. They can only drink things. They can't open their mouth to chew. Okay, this is no longer performed. It's the fixation, jaw fixation surgery. And if the person coughs or sneezes, it causes them a lot of pain. Apronectomy is also done. In operonectomy, any overhanging folds of excess skin, because once you immediately lose a lot of weight, you will have a lot of excess skin hanging over your body. Okay, so apronectomy is done to give you a good body image. Okay, artificial bezoar is done in which a balloon is inserted inside the stomach in order to decrease the stomach's capacity. And again, it is not as successful as other treatments, other surgical treatments. Coming to the prevention strategy, primary prevention, first of all, avoid situations that leads to overweight in children. Okay, but as soon as you see your child is overweight, make changes in their lifestyle so that they don't turn into obese. Directly from normal health, you will never go to obese. From normal weight, you go into a overweight category, and from overweight category, you go into obesity category. Okay, so prevent. Do take your strategies, do your planning, take action. as and when the child reaches the overweight category. That is the primary prevention. Secondary prevention, that is directed specifically to treat obesity. Keep motivating your children for an healthy weight. Okay, maintain a normal BMI throughout the childhood. Before pregnancy, what a mother can do: screen for glucose tolerance test. If the mother has diabetes, make sure the mother's gestational weight gain is normal. Okay, pre-pregnancy BMI is also normal. Prenatal nutrition should be optimal. Blood glucose should be under control for mothers. In infancy, exclusive breastfeeding for 6 months and continuous breastfeeding till 2 years. Okay, and weaning diet has to be done. Responsive feeding should be practiced. Only when the child cries for food, give them food. Balanced diet with the avoidance of calorie rich food or snacks, like anything that is deep fried has to be avoided. Closely monitor the child's weight gain. In preschool, again, nutritional education is given at school. Healthy food preferences are also given at school. Control the media time, social media time for the child, or gadget time with the child. For school going children and adolescents, at least 1 hour of daily physical activities should be put in their curriculum, out of which 30 minutes should be of any sports, extensive activities supervised by teachers. Sugars and free sugar intake should be very minimum. Reduce your saturated fat intake as well for teenagers as well. Then traffic light diet. So teach the children this. Green means food which has low calories and you can eat as much as you want. Okay. Yellow, caution, food that has moderate calorie, eat only in moderation. Red, high calorie food should not be eaten, avoid eating it. And add physical activity and behavioral therapy. This is the traffic light diet. Some metabolic syndromes are seen in children who have obese or who have the metabolic risk of to become obese. Too much of abdominal fat, excessive fat around the abdomen, um, too much of high triglycerides and low level of HDL and high level of LDL in their blood. Okay, if the blood test shows these results. Elevated blood pressure, high blood pressure seen. Insulin resistance seen in children and teenagers. Glucose intolerance seen in children and teenagers. High fibrinogen or plasminogen activator in the blood sample. Inflammation in the children. Okay, these are seen as a part of metabolic syndrome associated with obesity. And pediatric fatty liver disease. Okay, it also gives you steatosis or alcoholic fatty liver kind of symptoms are seen here. Jaundice will be here. Okay, it has to be treated under the pediatric guidance. Pediatricians will take care of this condition. Dietary changes, lifestyle changes, medications. Okay, these will be put in the child's routine to combat pediatric fatty liver. So that's about obesity and overweight issues in pediatrics. If you have